Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 198 of our Pharmacotherapy MCQ series, which majors in cardiology. And the first question reads, APM, a middle-aged patient is days post a successful heart transplant and is due for discharge today. So my question to you is, which class of medication would APM best be discharged on from the index hospitalization in order to prevent coronary allograft vasculopathy, abbreviated as CAV in APM's clinical scenario? Would it be A, a corticosteroid, or B, a statin, or C, an angiotensin-converting enzyme ACE inhibitor, or would it be D, a mammalian target of rapamycin, abbreviated as mTOR inhibitor? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, a statin. Although the mTOR inhibitors can attenuate CAV progression, they should not be used early after transplantation, making answer D incorrect. Although limited evidence exists supporting the potential for ACE inhibitors to affect CAV progression, these agents are also relatively contraindicated early after transplantation because of overlapping toxicity with tacrolimus, e.g., renal injury and hyperkalemia, making answer C incorrect. Finally, corticosteroids may prevent acute rejection, which is a risk factor for CAV. However, these agents play no direct role in preventing CAV, making answer A incorrect. Statin therapy following transplant remains the standard of care to help prevent the progression of CAV. Answer B is correct. Please advance to the next question. And the next question reads, JGP, a middle-aged patient who underwent a heart transplant 4 years ago is experiencing progressive decline in renal function on a regimen of cyclosporine and mycophenolate acid. So my question to you is, which of the recommendations listed below would be most appropriate in order to prevent further renal injury in JGP's clinical scenario? Would it be A, resume steroid therapy and discontinue cyclosporine, or B, change mycophenolate mofetil to everolimus, or C, change cyclosporine to everolimus, or would it be D, change cyclosporine to tacrolimus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, change cyclosporine to everolimus. Renal injury secondary to calcineurin inhibitor exposure is common, and the only effective strategy is to remove the offending agent. Hence, changing cyclosporine to everolimus would be correct. That makes answer C correct and answer B incorrect. There is no difference between cyclosporine and tacrolimus with respect to renal injury, making answer D incorrect. Although answer A would remove the offending agent, a combination of mycophenolate mofetil and a steroid is insufficient immunosuppression, making this answer incorrect because it would expose the patient to the potential for rejection and allograft loss. Please proceed to the next question. And the next question reads, TTP, a 67-year-old male patient who is now postoperative day 5 from a HeartMate 2 implantation is in your surgical intensive care unit. He has a past medical history significant for ischemic dilated cardiomyopathy. The cardiac team has achieved surgical hemostasis. TTP is therapeutically anticoagulated with IV heparin. So my question to you is, which of the regimens listed below would be the most appropriate thromboprophylactic strategy to recommend in TTP's clinical scenario now? Would it be A. Aspirin 81 mg orally once daily, plus warfarin with INR goal 2.0 to 3.0, or B. Aspirin 81 mg orally once daily, plus warfarin with INR goal 2.0 to 2.5, or C. Aspirin 325 mg orally once daily, plus warfarin with INR goal 2.0 to 2.5, or would it be D. Aspirin 325 mg orally once daily, plus warfarin with INR goal 2.0 to 3.0? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Aspirin 81 mg orally once daily, plus warfarin with INR goal 2.0 to 3.0. Data analyses regarding the optimal thromboprophylactic regimen for the HeartMate 2 device are limited. However, the available evidence suggests that INR values of 2.0 to 3.0 can effectively balance the superimposed risk of bleeding and thrombosis that affect these patients. Lower dose aspirin, i.e., 81 mg daily, can also help minimize bleeding risk, making answer A correct and answers B to D incorrect. Please progress to the next question. And the next question reads, PRA, a 74-year-old male patient presents to the ICU after drug-eluting stent placement for an acute myocardial infarction. PRA is in shock and is under tandem heart support. He is currently receiving a tandem heart infuse of 1000 ml of normal saline at 10 ml per hour. PRA's initial activated partial thromboplastin time, abbreviated as APTT value, is 32 seconds. So my question to you is, which of the recommendations listed below would be most appropriate in PRA's clinical scenario? Would it be A. Initiate argatroban IV with a goal APTT of 60 to 80 seconds, or B. Initiate enoxaparin subcutaneously dosed at 1 mg per kilogram twice daily, or C. Add 90,000 units of unfractionated heparin to the device infuse set with a goal APTT of 65 to 80 seconds, or would it be D. Initiate unfractionated heparin IV with a goal APTT of 65 to 80 seconds? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Add 90,000 units of unfractionated heparin to the device infuse set with a goal APTT of 65 to 80 seconds. The tandem heart device requires a heparin-based infuset in normal saline at a fixed rate of 10 ml per hour, making answer C the only correct option. Intravenous heparin alone, in answer D, is incorrect because the device manufacturer recommends that heparins be included in the infuset. Enoxaparin is not used for patients receiving tandem heart support, given the need for heparin in the infuset, making answer B incorrect. Finally, there are no indications of heparin-induced thrombocytopenia in this case, making answer A incorrect. Please progress to the next question. And the next question reads, which of the following statements best describes a known effect of mammalian target of rapamycin inhibitors, abbreviated as mTOR, in cardiac transplant recipients? Is it A, reduced long-term mortality post-transplantation, or B, higher risk post-transplantation, or C, lower risk of coronary allograft vasculopathy, or is it D, higher risk of cytomegalovirus, CMV, infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, lower risk of coronary allograft vasculopathy. The mTOR inhibitors have known antiproliferative effects and can therefore attenuate coronary allograft vasculopathy progression, making answer C correct. Answers D and B are incorrect because these agents lower the risk of CMV disease and malignancy. No evidence suggests a mortality benefit with mTOR inhibitors after heart transplantation, making answer A incorrect. Please advance to the next question. And the next question reads, WOC, a 77-year-old male patient weighing 120 kilograms presents to your accident and emergency department after developing severe chest discomfort, nausea and vomiting. He has a past medical history significant for ischemic heart disease, and type 2 diabetes mellitus. His ECG shows an ST segment depression in leads V2 to V4. His pertinent labs include sodium levels of 134 milliequivalents per liter, potassium levels of 3.5 milliequivalents per liter, a serum creatinine of 2.2 mg per deciliter, and glucose 182 mg per deciliter. His estimated creatinine clearance is 49 ml per minute per 1.73 meters squared. His cardiac troponin is 9.4 nanograms per milliliter. His vitals include a blood pressure range from 145 systolic and 90 diastolic to 153 systolic and 92 diastolic, a heart rate of 85 to 90 beats per minute. So my question to you is, which of the following interventions would best address the appropriate reperfusion in WOC's clinical scenario? Would it be A, coronary artery bypass grafting, abbreviated as CABG, or B, an early invasive strategy, or C, an ischemia-guided approach, or would it be D, fibrinolytic therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, an early invasive strategy. This man presents with new ST segment depression and positive troponin accompanied by angina and symptoms suggestive of a myocardial infarction. His disease should be treated as higher risk, since he is troponin positive, and he would benefit from an early invasive strategy. That makes answer B correct. Fibrinolytic therapy, in answer D, is not appropriate in this case because this patient presents with a non-ST segment elevation acute coronary syndrome, not an ST segment elevation myocardial infarction STEMI. Fibrinolytic therapy is indicated only in STEMI when percutaneous coronary intervention (PCI) cannot be performed within 120 minutes. That makes answer D incorrect. An ischemia-guided approach, as in answer C, is incorrect. It would be appropriate if this patient's disease were lower risk, troponin negative, thrombolysis in myocardial infarction, with a TIMI risk score less than 3, or a Global Registry of Acute Coronary Events score, abbreviated as GRACE score less than 109. Although this patient could go on to have multi-vessel disease requiring CABG, he must first undergo a diagnostic angiography to determine the best approach for revascularization. That makes answer A incorrect. The decision for PCI versus CABG is made after initial angiography. Please proceed to the next question. And the next question reads, MOW, a 65-year-old female patient weighing 60 kilograms, presents to your accident and emergency department with symptoms consistent with angina. MOW has no prior history of coronary artery disease. Her ECG shows an ST segment depression. MOW's troponin concentrations are negative. Her serum creatinine is 1.0 mg per deciliter. MOW's thrombolysis in myocardial infarction risk score, abbreviated as TIMI risk score, is 1. A diagnosis of unstable angina is made. An ischemia-guided strategy is planned. So my question to you is, which of the regimens listed below would be the best antithrombotic regimen, in addition to aspirin and clopidogrel in MOW's clinical scenario? Would it be A. bivalirudine 45 mg bolus and 105 mg per hour, or B. fondaparinux 2.5 mg subcutaneously twice daily, or C. enoxaparin 60 mg subcutaneously twice daily, or would it be D. unfractionated heparin, UFH 3600 unit bolus and a 720 units per hour infusion plus eptifibatide 10.8 mg IV bolus and a 120 micrograms per minute infusion? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. enoxaparin 60 mg subcutaneously twice daily. When an ischemia-guided strategy is chosen, guideline-recommended anticoagulant options are unfractionated heparin, enoxaparin, and fondaparinux. Bivalirudine is not recommended in patients undergoing a conservative ischemia-guided approach and would not be correct for this woman. That makes answer A incorrect. Eptifibatide, a glycoprotein 2b3A inhibitor, would be appropriate in a patient with high-risk features treated with unfractionated heparin. This woman has no history of coronary disease and does not have positive troponins. Also, her TIMI risk score is low and would not be considered high enough to benefit from eptifibatide. That makes answer D incorrect. Enoxaparin at a dose of 1 mg per kilogram subcutaneously twice daily is appropriate, given this patient's weight and renal clearance. That makes answer C correct. Fondaparinux is dosed once daily, making answer B incorrect. Please progress to the next question. And the next question reads, WPM, a 77-year-old male patient weighing 100 kilograms, presents with a chief complaint of chest pain that radiates to his left jaw. His ECG shows an ST segment depression. WPM's troponin concentrations are positive and they are reported by your lab as 7.8 nanograms per milliliter. He has a past medical history significant for coronary artery disease, type 2 diabetes mellitus, peptic ulcer disease with a recent gastrointestinal bleed, within the past 6 months. His current medications include pantoprazole 20 mg orally twice daily, and aspirin 81 mg orally once daily. His serum creatinine is 1.2 mg per deciliter. WPM is taken to the catheterization laboratory, where he undergoes percutaneous coronary intervention, receiving a drug-eluting stent, abbreviated as DES, to his right coronary artery. So my question to you is, which of the regimens listed below would be the best antiplatelet therapy to be added to aspirin 81 mg daily in WPM's clinical scenario? Would it be A. Clopidogrel 600 mg load, followed by 75 mg orally once daily, or B. Ticagrelor 180 mg load, followed by 60 mg orally twice daily, or C. Prasugrel 60 mg load, followed by 10 mg orally once daily, or would it be D. Cangrelor 30 micrograms per kilogram bolus, 4 micrograms per kilogram per minute infusion, then transition to clopidogrel 75 mg once daily without loading? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Clopidogrel 600 mg load, followed by 75 mg orally once daily. Answer D. A. Cangrelor infusion, is incorrect because the patient can tolerate oral medications. Prasugrel is not the preferred P2Y12 inhibitor in patients at high risk of bleeding. That makes answer C incorrect. Ticagrelor is a more potent P2Y12 inhibitor than clopidogrel and had higher non-coronary artery bypass grafting-related bleeding in clinical trials than did clopidogrel. However, although associated with less bleeding, the 60 mg twice-daily regimen has only been studied after the first year of dual antiplatelet therapy and is not recommended for this patient. That makes answer B incorrect. The best response is clopidogrel, and an appropriate loading and maintenance dosing strategy is provided in answer A. There is no significant concern for proton pump inhibitor clopidogrel interaction when combining clopidogrel with pantoprazole. Please proceed to the next question. And the next question reads, KHR, a 73-year-old male patient presents with a chief complaint to 2 days of intermittent chest pain that began when he was lying down. This pain, which radiated to his left arm, was relieved by aspirin and sublingual nitroglycerin at home. His ECG shows some T-wave inversions but no ST segment elevation. His troponins have been negative on 3 occasions. He has a past medical history significant for hypertension, hyperlipidemia, type 2 diabetes mellitus and depression. His vitals include a blood pressure of 145 systolic and 85 diastolic, and a heart rate of 92 beats per minute. His pertinent labs include an HbA1c of 5.6% at his last clinic visit. His total cholesterol was 143 mg per deciliter, with triglycerides of 226 mg per deciliter, high-density lipoprotein cholesterol of 33 mg per deciliter, and low-density lipoprotein cholesterol (LDL) of 65 mg per deciliter. His current medications include aspirin 81 mg orally once daily, atorvastatin 40 mg at night. percutaneous coronary intervention (PCIs) planned for KHR, and the interventional cardiologist wishes to use cangrelor in addition to unfractionated heparin. So my question to you is, which of the following would be the most appropriate monitoring of cangrelor in KHR? Would it be A. Verify now assay, or B. Activated partial thromboplastin time abbreviated as APTT, or C. Platelet count, or would it be D. Hemoglobin and hematocrit? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Hemoglobin and hematocrit. Cangrelor is a direct-acting P2Y12 platelet receptor inhibitor that blocks adenosine diphosphate-induced platelet activation. The efficacy and safety of cangrelor has been compared with that of the oral P2Y12 agent clopidogrel. Cangrelor has had better efficacy than post-PCI clopidogrel with increases in minor bleeding, according to the Champion and Phoenix trials. In other trials comparing cangrelor with clopidogrel, the incidence of bleeding was higher with cangrelor. That makes answer D correct. Thrombocytopenia has not been noted with cangrelor infusions. That makes answer C incorrect. No monitoring of APTT is necessary because cangrelor is an antiplatelet medication, not an anticoagulant. That makes answer B incorrect. Platelet function testing is not recommended for cangrelor infusions because this is a potent P2Y12 inhibitor infusion. That makes answer A incorrect. Please proceed to the next question. And the next question reads, PLY, a 65-year-old male patient is referred to the hypertension clinic by his general physician. He has a past medical history significant for type 2 diabetes mellitus and angina. PLY had a myocardial infarction 1 year ago and has been chest pain-free on clopidogrel 75 mg and aspirin 81 mg daily after drug-eluting stent placement at that time. His current regimen includes metoprolol 100 mg orally twice daily, and lisinopril 40 mg orally once daily. His vitals include blood pressure readings are consistently 150s systolic and 80s diastolic, and a heart rate of 64 beats per minute. His ECG is normal. He has potassium levels of 4.2 milliequivalents per liter, and serum creatinine of 1.1 mg per deciliter. His pertinent labs include a TC of 204 mg per deciliter, an HDL of 40 mg per deciliter, an LDL of 78 mg per deciliter, and a TG of 220 mg per deciliter. His current medications include simvastatin 40 mg at night, and metformin 850 mg after breakfast and dinner. PLY's HbA1c is 7.3%. So my question to you is, which of the medication changes proposed and listed below would be the most appropriate to address this patient's cardiovascular risk? Would it be A. Add isosorbide mononitrate 30 mg orally once daily, or B. Add hydrochlorothiazide 25 mg orally once daily in the morning, or C. Wean off metoprolol, start amlodipine, or would it be D. Change lisinopril to ramipril 10 mg orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Add hydrochlorothiazide 25 mg orally once daily in the morning. This patient's blood pressure goal should ideally be less than 130 systolic and 80 diastolic, according to the most recent guidelines from both the American Heart Association and the American Diabetes Association. Changing from lisinopril to ramipril would not be expected to provide the additional blood pressure lowering effect needed to achieve his goal blood pressure. That makes answer D incorrect. In a patient with angina not having adverse effects requiring cessation, beta blocker therapy should be continued because beta blockers are recommended first line in patients with stable ischemic heart disease. That makes answer C incorrect. Adding additional antihypertensive medication with a thiazide diuretic would be appropriate in this patient. That makes answer B correct. Adding additional anginal medication such as nitrate therapy is not needed at this time because the patient's anginal symptoms are under control. Furthermore, this would not be expected to lower his blood pressure enough to achieve his target blood pressure. That makes answer A incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 199.